Keynote lecture this year is being given by another very well-known leader in the field of women's health, Dr. Marcia Stefanik. Dr. Stefanik is Professor of Medicine and Obstetrics and Gynecology at Stanford University School of Medicine, where she is a faculty member in the Stanford Prevention Research Center. Her research focuses on chronic disease prevention across the lifespan, particularly heart disease, breast cancer, osteoporosis, and dementia. She studied the effects of menopausal hormones on health outcomes in several major research trials, including the WHI study, the HERS trial, and the PEPI trial, and her work has been widely disseminated both nationally and internationally. Dr. Stefanik was the chair of the Women's Health Initiative Steering Committee, and she was also the chair of the WHI Extension Study Committee, which oversaw the 5-year continuation of the project nationwide. She was also principal investigator on diet trials focusing on the role of low-fat eating patterns in preventing breast cancer recurrence, and her trials on the impact of diet, exercise, and weight control on heart disease risk and body composition have influenced national guidelines. We're very honored to have her here with us. Her topic today is the Women's Health Initiative, What Have We Learned? Please give a very warm welcome to Dr. Marcia Stefanik.
As he's fixing the computer, it's a great honor to be here, and particularly to do the Vivian Pinn lecture. Vivian is a very good friend of mine, and she was very important in the Women's Health Initiative. She played a very significant role in helping us maneuver through the NIH, through all of the stopping of the trials and all of the trauma that precipitated, which I think many of you have alluded to over the course of the morning. As soon as hopefully this won't take up my time. I'm going to try and use a pointer up here too, because I see that we have 4 screens. So first I just have to find the pointer. There we go. Okay, so this is really the 10th year anniversary of the Big Bang, which is when the estrogen and progestin trial first came out. So in honor of the 20th anniversary of this conference. As far as I know, I have nothing to disclose, so I'll just move on. And make the point that the Women's Health Initiative, although many of you know of it as a hormone trial, it actually had a huge diet trial that was larger than the hormone trial. And I'm going to give you some of the key findings from that trial, and also a very large calcium vitamin D trial, which I actually think kick-started this whole vitamin D craze, because people were very frustrated that the results didn't come out as they expected, and therefore they were basically feeling that we just had too low a dose. So we'll talk about that. The Women's Health Initiative also had a huge observational study. I'll mention a bit about that. The women that were eligible were aged 50 to 79 between the years 1993 and 1998. Actually, we stopped recruiting women who were 60 and over in 1996, younger than 60 in 1996. And they had to be living in the area of one of the clinical trials for at least 3 years. In addition to the big trials and the observational study, we were funded to follow the women for another 5 years after the trials ended, and that was the extension study 2005 to 2010, and we were funded again to continue to follow the cohort through to 2015, and I'll tell you about each of these pieces. So the Women's Health Initiative is unique in that it really does cover a lot of the country. Obviously, the Rocky Mountain states I wish we had one there, so there is a little blank there. But you can see that we have a large geographic distribution. It's actually been very interesting for looking at skin cancer data, which we're now looking at in the study. What you see, the red dots are the fact that we had 10 clinics that had a specific goal of enriching our minority recruitment, but all of the centers had that goal so that we were able to achieve our goal of 20% of the whole study being minority women. When we talk about the clinical trials, the diet trial, as I mentioned, was even larger than the hormone trial. It actually had nearly 49,000 women, with a focus on breast cancer and colorectal cancer, and then secondary outcome of coronary heart disease. And the hormone trials were really 2 trials, which I'll talk about, that had heart disease as its primary focus, and then had many other outcomes, because I think, as you all realize, estrogen affects just about everything. And so we really do need to be thinking about it in the context of a whole person, and not just be talking about heart disease and bone and this and that, as if they don't, as if it's all in a different person. person. The observational study was really designed to be a comparison or a control group so that we could get secular trends, what was going on in the country within women in the kind of the same group, somewhat like the control groups in each of the clinical trials. By and large, these were women who were not eligible for the trials, but had come in to hear about it and learn about it. There were a few women that came directly into the observational study, but most of these were women who, after they heard about being randomized to hormones, decided, I don't want to do that, or randomized to the clinical trial. We have had the opportunity to do a lot of really interesting biomarker research out of this cohort, and I'll talk a little bit about that. Speaking of talking, there's been a lot of discussion about WHI. This is kind of the time frame built in kind of a conversational way, where you can see that this was a complicated study. There were trials starting, stopping, observational study being published here and there, different things going on through the whole trial. So it was very complex. But the big bang, as I mentioned, is this 2002 publication of the estrogen and progestin trial, which were actually the preliminary results because we didn't even have all the data from the clinical centers. The clinical centers were actually surprised that the trial was being stopped, and so we really only had about 60% of all the results in when we first learned about that, and there was a mad rush to get as much in as we could. But subsequently, we've been publishing the very detailed data for each of the outcomes. So over the last 10 years, we've had very detailed papers for each of the outcomes, and I'll talk about a little bit about some of those. The estrogen-only trial was stopped a year and a half later, and so we'll talk about that. The diet trial was, as I mentioned, a very large trial. Women had to have at least 32% of their calories from fat to be eligible, and they couldn't have had any history of breast or colorectal cancer. The randomization you see, we ended up with 19,500 some women in the intervention. We had a lot of dietitians working on this intervention. It was a group intervention, very intense diet intervention. Anyone interested in diet should really look into what all we have in this rich database. And then the goals were very ambitious. Dietary goals of getting to 20% of calories from fat, using the NCI guidelines of 5 servings of vegetables and fruits a day and 6 servings of grain. We did not have weight loss goals. I will tell you there was significant weight loss in the intervention group in year 1, and they slowly gained their weight, but they never gained as much as the controls did. So there are weight change data built within this study that we are now starting to recognize that although that wasn't the intention of the intervention, we are now publishing what were the effects of those weight. But the important outcome was breast cancer. And what you see here is that at the top you can see the hazard ratio was 0.91, and it just missed significance, 1.01. Had that been 0.99, you would all know about the diet trial. So something you have to realize is that you don't hear about trials that aren't significant. And so you can see it would be your left. I'm really bad with left and right. On your left, you can see the cumulative hazard ratio, so you can see the breast cancers as they were being diagnosed, and the diet-only group was at a lower rate all along, but it really started to separate toward the end. So there was a 9% decrease, but it wasn't significant. It certainly gives us support for the hypothesis that reducing fat in the diet can in fact reduce breast cancer. And when you don't have a significant result overall, you do subgroup analyses. And so a subgroup analysis was done based on their baseline dietary fat. And first I do want to just mention, to see what you actually would get in an 8-year study of breast cancer, 3.5% of the patients develop breast cancer over this time. And that's including this 9% drop in the intervention group. But when we did it by baseline fat, remembering that they had to have at least 32% of calories from fat, the uppermost quartile, so those women who were consuming, based on a food frequency questionnaire, and there's all kinds of problems with diet assessment, but based on a food frequency questionnaire, the women who were at 36.8% of calories from fat or higher actually had a 22% reduction in breast cancer, and that was significant. So I think we have really strong messages that we should be getting fat reduced in the diet to reduce breast cancer. Colorectal cancer was a second primary outcome, and that one, 1% of all the participants developed colorectal cancer over the 8 years. There was actually no significant difference in colorectal cancer, but I will note that self-reported polyps and adenomas were significantly reduced, 9%. And an interesting issue about colorectal cancer is by removing polyps, we're actually simultaneously screening for risk and we're treating the risk. So we actually remove one of the risk factors. So in fact, that I think is in a direction of another positive outcome for reducing dietary fat. And then in the bottom panel are just the estrogen and testosterone data to point out that our hypothesis was based on the idea that reducing fat will reduce estrogen levels, and that would be the means by which we would reduce breast cancer. And in fact, we did have in a subgroup, a very small subgroup, because we did blood work, this is blood work, there was a significant drop in estradiol and some drop in the other estrogens. And sex hormone binding globulin, which is the primary carrier, was increased, which is an estrogen effect. So we at least were able to demonstrate that the hypothesis we were working with was also plausible. The other big trial that most people don't know much about is the calcium vitamin D trial. This trial was actually offered to women a year after they had been in either the diet trial or the hormone trial. And you can see that over 50% of women in the diet trial entered the calcium trial, and nearly 60% of women in the hormone trial entered that trial. This is really the largest trial of calcium vitamin D that was ever conducted in women, over 36,000 women. The intervention was 1,000 milligrams of calcium carbonate plus 400 international units of vitamin D, and it was a 50-50 randomization to placebo. Women had some choices about whether these pills would be swallowable or chewable, which actually turns out to help adherence quite a bit, because people like having choices. The sad thing for us, I think, was that we did expect to see a significant reduction in hip fracture, and there was a 12% decrease, but it was not significant when you look at the entire cohort. So again, you then go to, well, is there a group that really makes a difference? And just by not looking at the younger women, the women in their 50s, and focusing on the women 60 to 80, which is where most of our concern about osteoporosis was, and where all the hip fractures were, there were very few hip fractures in the women in the 50s, there was a significant 21% reduction by taking these calcium vitamin D supplements. However, there was no difference in colorectal cancer, and that was really quite surprising to people that truly believe that vitamin D would reduce colorectal cancer. And so this kind of launched the idea that 400 international units isn't enough. The new guidelines have been increased to 600, so not a huge difference in terms of what the guidelines are, but this is a very variable thing, and many physicians, I think you heard at the lunch, are talking about 1,000, 2,000. There was a risk associated with taking calcium vitamin D, and that was kidney stones. In the whole population, there were 17% increase in kidney stones, and so it's not a completely benign treatment, which is, I think, one reason that we're not really pushing it for women in their 50s, because we don't see the benefit and we see some risk there. So now I'm going to move, now that we've got Vivian Kim in the audience, I'm going to move to the hormone trial and make the point that it's really two trials based on whether you have a hysterectomy or not. And therefore, it's actually two study populations. Just about everything about the group of women who had the hysterectomy is different from the women who did not have a hysterectomy. And the question is, why do you get a hysterectomy? What are the characteristics that are going on? So I'm not suggesting for one moment that hysterectomy creates this difference, but there's a reason that people get hysterectomies that ends up resulting in two very different cohorts, and so it's very different trials, and people should really stop thinking that it's just the progestin that makes the difference between the results. So in a nutshell, if a woman had not had a hysterectomy, then she was randomly assigned to either placebo or estrogen and progestin in the form of conjugated equine estrogen and medroxyprogesterone acetate taken daily. And if she had a hysterectomy, she was assigned only to the conjugated equine estrogen or placebo. And what you see is these are huge trials. So the estrogen and progestin, which I'll refer to as the E+P trial, I've made it clear that I'm not talking about all estrogens. It is the conjugate equine estrogen that we studied. But the E plus P trial had 16,608 women, and the estrogen alone trial, which I'll probably refer to as E alone, had nearly 11,000 women. So as I mentioned, they're two very different trials. They had different follow-up periods because each of them were stopped early. The estrogen and progestin trial was stopped before the estrogen-only trial because the risk-benefit balance was seen before we saw that in the estrogen-only trial. But what you see is that the primary outcomes were the same: coronary heart disease. The secondary outcomes were the same: stroke, serious blood clots in the lungs and the legs. The cancer outcomes differed only in the sense that uterine cancer is possible if you don't have a uterus, so that one wasn't in the estrogen-only trial, but hip fracture, other deaths. And then I will mention the memory study, which I want to correct the comment that was the presentation earlier. The dementia study was restricted to women who were 65 and over. So there's not a mean age of 63, the mean age is closer to 74 for that ancillary study. So the way that this was set up based on the epidemiological data that we had at the time. And I think what's really important for people to understand is that WHI was never about menopausal hormones for treating menopause. We all believe that menopausal hormones have very good research to say that these are very effective for hot flushes and a number of the symptoms. It was designed to look at diseases of aging in women. And the reason for that is that in the early 90s, we really did have a medical practice that was encouraging older women to go on hormones after menopause to prevent heart disease and a number of other factors. So as a prevention researcher, that's what got me interested in this, is this the kind of prevention message we should be giving women? And it was based largely on the Nurses' Health Study, which for those of you who know that study was based on women who were 35, it was either 30 or 35 to 55, 30 to 55. So they were by and large premenopausal women, but some of those women did go into menopause. And so the data that came from the Nurses' Health Study was based on younger menopausal age women, and we were asking the question, do those data really apply to older postmenopausal women? So these are women after the menopause, 12 months after the last menstrual cycle. And the epidemiology suggested huge benefit for coronary heart disease by taking menopausal hormones. And there was an anticipated risk for breast cancer. And so the tear on the balance was set up, allowing for a lot of benefit to heart disease before we would stop the trial for the risk of the breast cancer. But there was also stopping rules based on the benefit, that if the benefit really exceeded what we expected, then it would be stopped for benefit. And I should tell you, most people expected this trial to be stopped early for benefit. It was a big shock that it was stopped for a different reason. And then lined up with the heart disease are other potential benefits. We certainly knew about bone. We expected overall mortality based on the heart disease relationship to death in women. We didn't really know about colorectal cancer. That kind of emerged in the epidemiology over time. We didn't really have a clue about stroke. It was bouncing back and forth even in the women's health, in the Nurses' Health Study, and we certainly knew about blood clots. That was kind of the first big thing back when the oral contraceptives came out at high doses. But what was really unique about WHI, I think, is that we had this global index that was focusing on overall balance and recognizing that when you start to take estrogen and progestin, you are affecting so many tissues of the body, so many disease states, that you have to look at the whole picture. Is this better off, or is a woman better off or worse off? Not just does she not get heart disease, but what about everything else? And so the global index was a second requirement of stopping either trial. You could have one of the flags go up for the a priori stopping for heart disease benefit or for cancer risk, but it also had to have an overall picture in that direction. So those were the stopping rules. Now, before I go on and show any results, which many of you are familiar with the basic line, so to some extent you're getting commentary, 10 years of commentary from having lived this study. So first of all, in terms of the idea that this was a study of older women, it was a study of a huge number of women in their 50s. The largest study ever done of women in their 50s. but the bulk of the data was based on women in their 60s and 70s. So about a third of the study was women in their 50s, 45% were in their 60s, and nearly a quarter were in their 70s. And these slides is showing you the percent of women within the age group for the overall cohort by the two trials. So the gold, the yellow is the E+P trial, and the red is the estrogen-only trial. And that's not based on randomization, it's just based on this total thing. So the trials were pretty similar in terms of their age scope. So the E alone trial was just slightly older than the estrogen and progestin trial. But that's really important to remember because many people have the idea that the trial was too old, but then they forget about that when they're talking about the E alone trial, that they were even older. So just to kind of remind you of that. The other thing I want to remind you of is that the ethnicity, the race ethnicity breakdown was quite different in the two trials, in that a large percent of women in the country have hysterectomies. When we talk about what the age difference is, it turns out that women of color tend to get their hysterectomies at earlier ages than do white women. And so we never shut the study down to younger women of color. And so what we ended up with is a much, much higher percent of younger women in the race ethnic group. So you can see that when we talk about the overall trial, 33%, a third of the estrogen-only trial were women of color. Compared to when we look at the women in their 70s, it was a much smaller percent. So again, many people don't realize that we really do have two very different trials with very different race ethnic breakdowns, but they were of similar age. So the first thing was the estrogen and progestin trial. And the flag that went up first was breast cancer. This was much earlier than we expected. The data that we had from the observational literature did not expect us to see breast cancer showing up by 5.2 years. The overall study, as I mentioned, was actually longer. We had a lot of data not yet in the clinic, not in the coordinating center, so it's an average of 5.6. But the preliminary data that kind of shot the cannon off was first breast cancer. There were also DVTs already showing up. But that did not stop this trial, because would not have stopped it, because by that time there were already enough benefit to bones and to the colorectal cancer that we didn't expect, that those two together balanced out the breast cancer risk. And so the global index was going to be the thing that really made the difference. And basically, the big shock was that instead of being on the side of benefit, we had more heart attacks, more strokes, and the expected, but much higher than we expected, blood clots. So that clearly was a picture of risk exceeding benefit. Now, a lot of people then started focusing on the concept of relative risk, that percents don't tell you what's the absolute risk. And so this is something that became actually part of the media, which many people are still quite confused about, but a lot of discussion started to go on about how do we put into account relative risk and absolute risk. And so this is a graph that you have seen probably in your clinics in some form. And I've heard people say things like, well, 7 per 10,000 per year more heart attacks is not that big a deal. But I can tell you, if a 29% decrease had happened, 7 per 10,000 per year would be a big deal, and every person in this room, including most of the men, would be on these hormones now. So the bottom line is it's a big deal. And when you start to add then the 8 per 10,000 per year more strokes, the 8 per 10,000 more breast cancers, and the 8 per 10,000 more blood clots in the lungs, pulmonary emboli, you really have a picture of risk that exceeds benefit. So the other thing I'll quickly tell you is that, and I should also quickly say the benefit. So the benefit was the colorectal cancer and the hip fractures, and you can see those absolute risks are much smaller than the ones that people have been discounting. So it's a little challenging when you're trying to talk about prevention for women, older women. And another big thing of prevention was dementia. And I can tell you when I talk to participants that you have to come off your pills, they would say to me, I can't come off my pills. My daughter's so worried I'm going to get Alzheimer's disease and dementia that she really wants me to stay on this pill. And I said, well, we don't have good data on that. But we did very shortly thereafter, because we had to stop the WINS trial, which was restricted to women who were 65 and over, recruited at the time that we randomized for the whole trial. The outcome was probable dementia. This was the largest study ever done on this question. So in the E+P trial, we had over 4,500 women randomly assigned to the same hormones that we talked about. In the estrogen-only trial, there was nearly 3,000 women, and they had to stop at the same time, but they had started later, so the follow-up is actually much shorter than the main trial, just because of the way we were recruiting older women, so it's a little complicated. But the important thing is, we were doing these cognitive assessments every year, so this is why you see this step pattern, because we weren't picking up the dementias until they did the test. But the bottom line was, the estrogen and progestin group had twice as much probable dementia as the placebo group. So instead of improving and reducing dementia, it actually increased dementia twofold. So that was the next big shock. And I can tell you that this was a huge story. I think those of you who were paying attention at the time got it. The good thing was it did then shift our attention to menopause and the fact that we didn't understand menopause. We thought we have the solution to menopause, take estrogen and everything's fine. And now we have this problem that, well, wait a minute, we better start looking at this question and it's time to study women and let's start studying menopause and what is the cause of menopause. But the WHI was not about menopause, and it's really important that you understand. It was about preventing diseases of older women. That said, I will point out that the prescriptions dropped precipitously. So this is showing you the estrogen and progestin. I can try and use my point. Well, I think you can see the points that the estrogen and progestin is on the total is on the top, big drop, and then estrogen and progestin is the curve that also has a big drop. And I'm very happy to say that the media was at least giving the message out that we don't know yet about estrogen, and estrogen only wasn't having this big drop. It was very clear that people were focusing on estrogen and progestin. So what about the estrogen-only trial? Hadn't even come out yet, and all that happened. And I can tell you that by the Data Safety Monitoring Board is looking at the data every 6 months. At 6.8 years, a decision was made to stop the trial. There was no effect on coronary heart disease at that time, and there was no effect on breast cancer at that time, and no effect on colorectal cancer. But what stopped it was the fact that there were significantly more strokes. And even though the stopping rules would not have stopped this trial, because there was also benefit to hip fractures, the National Heart, Lung, Blood Institute felt that they could not continue a study that was actually causing increased stroke, even though the bone and the overall picture was a balanced picture. There you get into, you've got to tailor it for the individual woman. And again, the absolute risk, you can see that only the stroke had the absolute risk of now 12 per 10,000 more per year, as opposed to the 8 that we saw in the estrogen and progestin trial. And I will just quickly tell you that by and large, the women in the estrogen trial were at higher risk for heart disease, so the placebo group also had more heart attacks than the active group in the estrogen and progestin. They had more strokes, so they were having more cardiovascular events, and adding estrogen didn't have as big an impact on their events, or didn't have an impact on their events relative to their already elevated risk. At any rate, you also see the benefit to hip fracture, which was much lower than the risk to stroke. So the overall picture is one of a concordant result, and I better move a little faster here. Absolutely the same results for heart disease, no benefit, and in fact this higher risk for E+P. For strokes and blood clots, clearly harmful. For fractures, clearly beneficial. Dementia was harmful, and we actually did a brain MRI study afterwards that was published in 2009 that showed that it wasn't vascular dementia. It was, in fact, a reduction of brain volume, particularly in the amygdala. So the very areas that you saw on a previous slide, getting estrogen at a later age actually causes a reduction in very important areas of the brain. The breast cancer was opposite results, so we'll get to that. Colorectal cancer actually had opposite results as well. So the cancer data are different in the estrogen and progestin estrogen trials. Now, where a lot of attention was drawn was to this particular piece of data, where a lot of focus was on the younger women in the estrogen-only trial. So the first thing I want you to know is that this was not true in the estrogen and progestin trial. In the estrogen and progestin trial, younger women had more heart attacks if they were on the hormones. It only applies to estrogen only. And it actually, what drives this interaction is the upper end that I don't have circled, which is the older women. The older women were having significantly more heart attacks on estrogen only, but the younger women were having fewer. It's a really small number in the end, but it's really kind of launched itself into public recommendations. And I'll also tell you that we did a sub-analysis of women who had vasomotor symptoms on out into the older ages, and the women who were still having hot flushes in those older ages had the worst outcome when you add the estrogen. So definitely don't start estrogen in older women. We have very good data now to show that we probably have different physiology, and we need to understand that physiology. That's really important. But to kind of move on, I just want to make some points that when we look at the younger and older women, they are very different within these trials. So for instance, I'm just going to focus your attention on the estrogen-only trial and point out that when we look at the women who were 50 to 59, more than 50% of them were obese, and less than 20% were normal weight. So these younger women were not your generally thin women that were worrying about for osteoporosis. They were a very different group of women. And then you can see that they differ quite a bit from the women in their 70s, where 34%, it was more of a one-third, one-third, one-third. And quite a bit more obese than the estrogen and progestin trial cohort. The other thing is that they clearly had different prior hormone use. That all needs to be taken into account. This is really where we started looking at the gap hypothesis that you heard about earlier, trying to figure out if you had hormone use before, what are the differences. Now I'm going to have to race to the end here and talk about the fact that we continue to follow the women to see what happened after they stopped, because that was the next question. I'm going to come off my hormones, what am I going to do? And so in a nutshell, in the estrogen and progestin trial, all the risks disappeared within 2.4 years of stopping the hormones for heart disease, stroke, blood clots. Fracture also disappeared, so what you have to realize is that going on the hormones, preventing those fractures in that 5.6-year period doesn't mean that you're going to end up that much better off in the end, because all the benefits disappear in a really short time after you stop taking your estrogen and progestin. Now, the breast cancer is a more interesting story, so rather than jump to that, I'll just go and say what happened in the meantime was the SEER data came out and showed that concomitant with this drop in hormone use across the whole country, there was a significant drop in breast cancer in the whole country. And if in fact you go back and look at the breast cancer data back in the 90s, you'll see that there's a very precipitous rise in breast cancer that completely mirrors the rise of hormone use. So I feel that we have a pretty good piece of data showing that the hormone use, estrogen and progestin in particular, clearly affects our breast cancer risk across the country. And we actually looked at this in WHI. This is a really complicated slide. I don't know if I can figure out the pointer here. So here's the pointer just to show you that during the trial, we had the significant increase in breast cancer in the women on the estrogen and progestin. Here they stopped, and here you see this decrease. So there actually was, we were able to show within the trial this decrease. I will point out that the hazard ratios are identical, because hazard ratios don't actually tell you the direction of changes that are happening. So a hazard ratio is a little deceptive, and we do need to start being more time sensitive. In the observational study, we also had the opportunity to look within our own cohort, and I can show you, this is the women who on their own were taking estrogen and progestin versus not taking it. Twofold higher rates of breast cancer, very steady across the study, twofold higher rates. Here they've come off their hormones because of the WHI experience, drop in breast cancer. So it's very, very clear that we had a huge impact on the health of women in this country. Now, estrogen only, I will tell you, it's a little more complicated because women were coming off their pills. And in fact, by the time we stopped the trial, more than 50% had come off their pills. And so when we actually looked at how long were they on the pills, and you start getting into some other kinds of analyses, the mean adherent time was only 3.45 years. So all the data that you're hearing now about after stopping estrogen, you have to realize this is based on guidelines, short-term use. 3.5 years is a reasonable amount of time for a woman to go on hormones and deal with menopausal symptoms. And then what happens is we're basically able to see that during the intervention we had all of these different issues. Post-intervention, the blood clots go away, they actually drop. The breast cancer decrease was, and this is what is significant in dark colors and then what's not significant in white. You see the breast cancer wasn't really significant, but over the whole course, going on hormones for a mean adherent time of 3.5 years, coming off of them for about 3 years, which I think is absolutely consistent with current recommendations. We actually would expect for younger women in particular this decrease in breast cancer. But that's the use. We're not talking about going on it for a long time, and we're not talking about on for permanent. And just to kind of come to the end of this, when we look by age, we do see a significant drop in the heart, the cardiovascular events, and a significant increase for older women in the cardiovascular events. And over the course of the study, we see different age groups. And to just come to the bottom line, the bottom line I think here is really that it probably is fine. We're very reassured that for younger women, women in their 50s, that you're not going to increase breast cancer, you may actually decrease breast cancer with short-term use. We're not talking about the rest of your lives. And I will tell you that it's not true that hormones has taken a rebound. This is actually looking at what's happened to hormone prescriptions over time. Slight increase now in estrogen only, which I think is appropriate. I think we have a good profile for estrogen only. In the extension study, we've also been doing GWASs, particularly in African American and Hispanics, to look at the genetic factors. We've added CMS linkage, so we're getting a lot more information. And I'll end by talking just to mention that we are still following the women. You can actually, I'll leave this up while I'm answering questions, so you can study to see what percent of the original population is still involved in the study, what percent of the ethnic group is involved in the study. And I will tell you right now we're working on a huge new trial within the cohort of physical activity to look at whether we can prevent heart disease with physical activity. So now I'll take questions. I can't hear you.
I work with a group who just completed a meta-analysis on the relationship of BMI and breast cancer, and we were really interested in the paradoxical effect of premenopausal breast cancer and postpartum. So my question for you is if you have a subgroup analysis or stratification based on BMI within those breast cancer results?
Yes, we did, and so they're published in the main papers. So in the estrogen and progestin trial, it's quite interesting that the BMI, as the women's BMI goes from normal weight, overweight to obese, their risk climbs up very, very dramatically. And there's not an interaction where there's even more if you go into the hormones, but it's very similar, so that when you look at the hormone effects, it's almost equal to aging 10 years by the BMI categories. We didn't see that for the estrogen-only trial. So the estrogen-only trial didn't have the same relationship, and when we talk about premenopausal and postmenopausal women, premenopausal